Good evening. Deleterious consequences of EVAR explantation. Conversion to open repair after EVAR is associated with significant morbidity and mortality. The incidence of late open conversion after EVAR approaches ranges from 1 to 23%. Graft explantation is a technically challenging procedure that places considerable physiological stress on the patients, leading to morbidity rates of 35%. From the VascuNet Explant project, 348 open surgical conversion patients from 17 centers. Most common indication for open surgical conversion was endoleak, mostly type 1 endoleak. The median time from EVAR to open surgical conversion was 4 years. The median abdominal aortic aneurysm diameter at open surgical conversion was 7.5 centimeters. The 30-day mortality rate was 6% for elective cases and 30% for ruptured cases. The multivariable analysis revealed that ruptured and total graft explantation as the only statistically significant predictive factors for 30-day death. I would like to represent a case done at our Ain Shams University Hospital, Demirdash Hospital. This is a male patient, 71 years old, diabetic, hypertensive, history of straightforward EVAR for infrarenal abdominal aortic aneurysm 4 years ago. Patient presented with back pain and pulsatile abdominal swelling. CT scan revealed infrarenal aortic aneurysm and with a sac diameter of 8 centimeters with intact pedal pulsations and normal labs. This is the CT angiogram. We see here the proximal fixation, the aneurysm sac, and both limbs. A medial laparotomy was done, the supraceliac aortic control and both common iliac arteries exposed. Exposure of the aneurysmal sac, both renal arteries and supramesenteric arteries to reveal the proximal fixation barbs, and the barbs were extending beyond the aortic adventitia. The sac was open, the EVAR device was cut into half, the iliac limbs were extracted smoothly, and the clamps were placed on the both common iliac arteries. The remaining of the device was extracted using a 20 millimeter syringe. A tear between the renal arteries and the supramesenteric arteries was seen after extraction and repaired directly by Prolene sutures. And then a straightforward bifurcated background graft was placed, aorta by iliac bypass, and the sac was closed. This is the graft cut after explantation, and this is the pantalon graft placed. Unfortunately, the anesthesia doctors told us that the patient had no urine output for more than 1 hour despite intravenous fluids and intravenous diuretics. So, a left transbrachial axis was gained, a guiding catheter was placed for angiography of both renal arteries, and no flow was detected in both renal arteries distal to the ostia. This is the CT, this is the intraoperative angiogram. Trials of wire passage were unsuccessful. The patient was reopened and a direct puncture into the anterior wall of the native aorta in front of the renal artery, in front of the left renal artery was done. We passed a 6 French sheath wiring the renal artery and placement of a 7 millimeter, 6 centimeter self-expandable stent. This is the stent after placement, but the picture is hazy, kind of hazy. This is before stenting. This video is before stenting. We couldn't access the right renal artery antegradally, so we exposed the right renal artery up to its segmental branches and made a puncture into the segmental arteries, into one of the segmental arteries, and we passed a wire retrogradely into the aorta. And this is the photo. This is the renal artery. This is the one of the segmental branches, and we passed the wire into the native aorta. as we couldn't pass antegrade. And we placed a 7 millimeter, 60 millimeter self-expandable stents into the renal ostia. Both renal arteries and parenchymal branches are now patent. Post-operative, the patient had a urinary output of less than 50 millimeters per day and rapidly elevating serum creatinine. He underwent 6 dialysis sessions. The patient was discharged home with a serum creatinine of 2.5 milli per deciliter and a urine output of 50 milliliters per hour. The total hospital admission was for 17 days. The patient is currently doing well, but the operation is only 4 months ago, and the patient needs more follow-up. What I learned: following explantation, one must check the visceral and peripheral perfusion, not only clinically, but also angiographically. Prompt treatment of operational consequences can extend the patient's lives and improve quality of life. Complications can be safely managed with recent endovascular means. Strict post-operative follow-up is crucial for better outcomes. Thank you.